So the way that I was thinking of doing this is instead of having a slide deck, I'm going to do Chalk Talk version of Dr. May, which I actually like doing a lot better. Because that way you can, I don't know, see the thoughts unfold. But I think so what I wanted to do is take kind of the more infamous rumors that we've all been exposed to about the COVID-19 vaccine and try to go through, all right, where does that come from? What is the reality behind that? And how do we talk about it? Kind of same as we did for the other vaccine myths, because I think that's kind of an effective strategy. All that being said, I may very well have missed one or two. So if you heard one that I don't get to, like, please bring it up and we'll see if we can sort through where it comes from and, you know, and what's going on there. The other thing though, and this isn't really so much a mis or disinformation point, it's more of a, but it is a point that people make a lot when you're talking about the COVID vaccine. And so I think that the important context to start with is that COVID as a disease, we tend to hear about it discussed as though it has like binary outcomes. Either you get it, you get sick and you die, or you get it, you get sick and you recover. And I think we have to appreciate that's not remotely the case. There are people who are, you know, these dire long-term consequences. You know, I mean, I think we can all think of someone in our lives, but, you know, I've at least a handful of friends who got sick very early on, you know, in January or February of 2020, and they're still dealing with physical manifestations of their disease. You know, one has, you know, long-term cardiac treatment that she still has to undergo follow-up for, you know, over a year later. And so that to me, it feels like that's getting lost in the conversation, that we don't just have this disease with these two very neat, clean outcomes, that we just have this incredible number of people in the middle who are just dealing with new and potentially lifelong disabilities that they didn't have before. And so that to me is a really important answer when people say things like, well, I'm young and I'm healthy, and if I get it, it'll probably be fine. Because I think we've all rightfully kind of thought of a great response to that argument being, yes, but you could give it to someone who won't be fine, which is absolutely true. But then you could have an instance where someone who's maybe 20 years old and healthy can say like, well, my parents and my grandparents have been vaccinated, so they'll be safe. So if I give it to them, they won't get infected, or they'll get, you know, something really mild. So I'm fine and I can't give it to someone else. But especially now with the Delta variant, that one of the things that we're seeing is that this is absolutely wreaking havoc on younger adults and on kids in a way that the original variant and the Alpha variant weren't. So that might have been a completely valid argument, you know, 8 months ago. You could have had someone who's 20 making that point and say, you know what, you're right, that's your decision, that's fine. But now it's just, I would feel remiss if the opportunity wasn't taken to say, you know, you could wind up with a long-term disability out of this. And or it's not just, you know, grandma that we need to worry about now. Now we have to worry about people like my unvaccinated 8-year-old, because there are entire states where there are no PICU beds left in the entire state. And that is a terrifying prospect. So anyway, that's kind of a general context that I kind of wanted to use to set the stage for things, because there are kind of the standard rumors with the COVID vaccine, but there are also people who are making a choice kind of absent the full picture And I think those are the people that are, you can really have an influence on. Because if you have a 22-year-old who really genuinely does not know, they may be risking, lifelong heart problems. They may change their decision about getting vaccinated if they know that. So anyway, so that's the context. Now, here are the crazy rumors that I've heard, and then feel free to chime in if I've missed any. So here are my favorites. Okay, you have the classic, it will change your DNA. All right, so I'm gonna make a list. Change DNA. All right. Next one. Causes infertility. Okay. 3. It has antifreeze in it. And this is one that it kind of sounds crazy, but it's almost like the ethyl versus methyl mercury issue. Like there is an ingredient that is a different, organic version of the primary component of antifreeze. So it's one of those, like, there's like this little teeny kernel that got like spun wildly out of proportion, but so it's not a complete, like, off the shelf lunacy thing, but it is very easily correctable if you know that much chemistry. You can say, okay, I know how that sounds, but all right. And okay, 3. 3 comes after 3. 4 comes after 3. And number 4, it was rush. Okay, so those are my favorites.
Anyone in T wanted to inject a disinfectant?
I'm sorry. No, the injected disinfectant aside, that's I guess we can say safely that is different than a vaccine, or we could do so I think, like, all joking aside, that one can be like, when people bring it up, it elicits laughter, but sometimes it elicits, it's not what he said. I was watching it live. It's not exactly what he said, but it's not what he said. And so, but people get kind of genuinely, like, people have feelings when you bring that up. And so I think a good way of neutralizing that and moving on would be to say, well, right now we're talking about prevention, not what happens if you already get it. So vaccine, moving on. Let's leave that one alone over there. Anyway, so those are my 4. Has anyone heard any others other than that? Yeah.
Microchip?
Oh, the microchip. Although honestly, that I'm sort of like, I don't even know where to start with you.
Quote unquote, not convinced.
That's a good one. Quote unquote, not convinced. Okay, so not convinced is a really good one, because that is something you hear from people who are, not in the microchip category, and that's a tough one.
Yeah.
Okay.
Really?
It really is. But I have some ideas. Okay.
I love that.
So okay. So I'm going to start up here for changing DNA. All right. And I'm going to see if I can pull this down. All right. So right now, I heard it can change your DNA, and specifically in this case, we're talking about Pfizer or Moderna, the mRNA vaccines. All right. So let's remember a little bit of block one cell biology, shall we? All right. And this is, I think, sort of an effective thing to do. Just grab like a paper towel or a napkin or whatever, back of an envelope, and draw a cell. Okay. And you can say, all right, think back to, high school biology. This is the level that you need to understand this on, because you don't have to get into incredible levels of cellular biology to really help assuage that worry. Okay, so you draw a cell. All right, where's the DNA in the cell? Where does it live? Yes, it lives in the nucleus. Remember, in a eukaryotic cell, the nucleus has this nice membrane around it. If anything's going to get into the nucleus, do you remember what it has to have on it? So, not important to bring up the term, but everything that gets in there has to have either a chaperone or a nuclear localization signal, something that is going to allow it to get in here, right? Because that's where the hardware is. That's where the important stuff is. So you don't let just anything into the nucleus. So the nucleus has a whole bunch of like bouncers. And if anything doesn't have their name on the list by having a localization sequence or a chaperone, it's not getting in. Okay? So the first thing we can remind people of that your DNA lives in here, and this is kind of walled off from the rest of the cell. All right, so that's point number one. Point number two. What does mRNA, what's the point of mRNA? So it drives and directs something for protein translation, because it will then make a protein which will then do stuff. In this case, serve as an antigen to make your immune system recognize the spike protein of SARS-CoV-2 and protect you from COVID-19. Okay, so what makes the proteins? Yeah, where do those live? Rough ER, which is outside the nucleus, right? Okay. Rough ER over here, and all the ribosomes are hanging out on the surface of the rough ER. All right, so drawing obviously not to scale. mRNA comes in here to build spike protein. Where is it going to go? Right over here. Okay. They're going to make friends. They're going to make spikes. All right. Spikes are made. Immune response happens. You're missing gaps in between. Spikes are made. Immune response happens. Life is good. Does this ever go in here? No. Can this ever touch that? No. No. Because it can't get past the bouncer. Also, it doesn't want to get past the bouncer. It has no interest. It wants to go over here. It's like, I don't want to get into that nightclub. I want to go do yoga and go to bed. That's what it wants to do. It wants nothing to do with this. Okay. Alternatively, if you've got someone who's got a little bit, I'm not quite convinced. All right, fine. What can integrate into DNA? RNA or more DNA? More DNA, right. So RNA doesn't have a way of physically interacting with DNA. Only other DNA does. Do we make any enzyme that will read RNA and make DNA? No, because we are not retroviruses. That I know of. Rachel looks a little sketchy, I don't know. I'm sorry, I'm teasing you. You were like, I said I was not going to help with this presentation. So yeah, essentially we don't, not only can these two things not contact each other, we don't have any tool that will read this and make that such that it even could interact with each other if they were somehow to wind up in the same physical location. So what you can do, and I would really kind of keep it at this level, like the bouncers, and they're in the nightclub, and here's the yoga studio, and you'd rather be here than there, and blah. Because when you start saying like messenger ribonucleic acid, people kind of shut down. So I would grab an envelope, grab a piece of paper, draw a picture, and just be like, this here, nightclub bouncers, no, they can't physically interact. So that's not a thing. This sounds like, yeah, we're injecting genetic material, and that sounds, it's futuristic and scary, and that's, how do I know that's not going to change things? And you can say, I know it's not going to change things because it can't physically get at the thing that you're worried it might change. So I think that's mini cell biology lesson makes that one go away. All right. Changing DNA, not a pain. All right. Next up, causes infertility. Okay. So, you've heard that one. I heard that one a bunch. We all heard that one a bunch. Yeah. And part of me, I know now where this came from. When it first started making the rounds, it was sort of like, what the heck is this about? I have no idea what anyone is talking about with regard to infertility. Part of this, I think, is, and I think it's now been fairly well established that a lot of the vaccine rumors are coming from professional disinformation generators. Part of the psychology of disinformation is that you start by terrifying the person so that you activate the part of their brain that goes into fight, flight, freeze mode. And then you give them little factoids that sound convincing, and they're more likely to grab onto that because you've activated this very, reptilian part of their brain. Here's a fascinating article about, apologies for being quasi-political, there's a fascinating article about the structure that Tucker Carlson uses to put his pieces together, using very much that strategy that you introduce a scary, terrifying thing, and then you give quasi-iffy facts that if you read them on paper in a calm state, you would be like, I don't know, that doesn't sound right. But because you're kind of in that mode, it's more convincing. So I think infertility, it was intentionally chosen in a way, because if you say to a young person who has wanted all their lives to be a parent and have a baby and everything, say, if you take this, that'll take that away from you. And on the other hand, you also have this, well, if you get sick, you won't die. You're 22, you'll be fine. And now that mom and grandma are all vaccinated, that there's no need for that, because why would you risk infertility in the future if this disease isn't going to really hurt you? And that feels like a persuasive argument. And I can't promise if I were 23 that might not have landed on me a funny way. Like I could see why that is so seductive, because we as biomedical researchers cannot yet say that will never cause infertility 10 years from now, because it has not existed for 10 years. There is absolutely zero reason why it would, and the science behind the rumor is not a thing, and I'll go through that in a second, but this is a difficult, it's actually a little bit like the lab leak theory. When somebody kind of sticks their finger in your face and says, prove to me that this doesn't cause infertility, you'd say, well, I can't do that. Like, that's not how proof works. Like, I can't prove a negative thing in an elapsed amount of time that has not yet occurred, at least on this timeline. I don't know if there are low-T's and variants that could, prove otherwise, but maybe if one appears, we'll know. I don't know. Hope it's not crocodile. Anyway, I forget. I really hope people would watch that show, or I sound like a weirdo. Anyway, so when somebody kind of aggressively says, prove this, and you kind of are caught back on your heels saying, well, that's not a possible thing to prove, then that gets taken as, see, they can't prove it. They're hiding something, or they don't care that that could happen. You're like, no, that's not what just happened here. What just happened is you asked me to prove something within 5 years for a thing that has existed for 18, for 12 months. And that's not how time works. And in any event, but it's like too late at that point, because this big scary thing has caused the reptile brain activation, and you have this person demanding, save our fertility, we love babies, and this other person going, what? No, well, I guess I can't prove that, but, and then you lost the argument. So there's that. So that's kind of the landscape that we're dealing with and working with. But here's the science. Allegedly. Okay, so maybe give me a quick 2-second primer. What is autoimmunity?
Immune system attacks parts of the body.
Yeah, so your immune system attacks part of your own body. All right, so here is what has been alleged. Like protein of SARS-CoV-2. It has a certain shape to it, as proteins do, right? Now, someone, somewhere in the world, began alleging that there is a protein in the placenta during pregnancy that's kind of sort of shaped the same way. And so the allegation is, when you induce a patient to make antibodies against the spike protein, or reactive T cells. This is my T cell receptor. Sorry, it's kind of jumped open. In case it's not clear, I have terrible handwriting.
That circle's great.
I can do circles and squares. That's it. That's the extent. I'm like an 8-bit Nintendo. So basically, the allegation is, when you stimulate a patient to make these antibodies and these primed TCRs against the spike protein, that someday, if pregnancy occurs and a placenta develops, this will then attack the placenta and cause pregnancy loss. So that's the science, alleged science. And this has now, that's when it first was discussed. Now it's kind of morphed into like dropped sperm counts, and because we gotta rile the sperm makers up as well. We can't just have the placenta makers riled up. It's everybody. Disinformation works half as well if it only targets one part of the population. And it is also kind of morphed into, it will prevent ever, you ever becoming pregnant or things like that. So that's the kernel of where it started, and then it has snowballed. Because all infertility is obviously exactly the same. Sorry, I'm making a face and rolling my eyes in case that was not clear. All infertility is very complicated, and there's several different ways infertility develops. Okay, so how do we know this is not a thing? Because on paper, it looks like it could be a thing. It's not a thing because when you look at the computational protein structures, they're not that similar at all. And so looking at it from a computational biology standpoint, it didn't make any sense to me that this would be a thing, but somebody actually did the experiment. So what was done was that purified placental protein was generated and was basically adhered to the bottom of an ELISA plate. So basically, if there's like a little well of plastic, they put I gotta draw the same random shape. They put the placental protein, they lined the bottom of the plastic membrane with it. And then they took antiserum, so they took basically plasma that would contain antibodies from vaccinated patients and from patients who had recovered from COVID infection naturally. And they poured all the antibodies on, again, both vaccine-derived and natural infection. And they saw, did they stick? They did not stick. So not only is it like, it doesn't look like they would interact, but we can actually say somebody did the experiment and these two things, vaccine-derived antibodies, anti-COVID antibodies, do not stick to this protein. So not a thing. In addition to that, during the Pfizer clinical trial, they're the ones who actually released this level of data. Moderna may have, and I didn't have time to look it up honestly, but Pfizer did. And during their phase 1 and phase 2 trials, they had advised participating women don't pursue pregnancy during the trial because we haven't thought about that, we haven't considered it, so just don't do active family planning during this clinical trial. However, for some people that doesn't always go according to plan. So in the phase 1 trial, 23 women became pregnant. And out of those 23, there was but one miscarriage, and she was in the placebo group. So so we can actively say it doesn't make sense on paper, it doesn't work in a laboratory, and it doesn't work in the clinical trial, even though, again, that's not what the trial was designed for, but it did give us that insight that, incidentally, we actually had a group of women who received this vaccine during the establishment of their pregnancy, and it did not induce spontaneous abortion. So, not a thing, not a thing, not a thing. Okay, yeah.
What's the rate of miscarriage just in the general population? Just
Way lower than that. I know you could, it's a small n, so you would never actually say this, but you could be like, look, it actually prevents miscarriage. Like, so it depends on, it's a complicated question because you have to break things out by age and things like that. But it's way lower, or it's way higher, I should say, than 1 in 0.3. it's right around 1 in 4 is my understanding. Again, with 1,000 caveats to, at different rates and different subgroups. Yeah.
Is there any science behind the sperm maker ideas? I've heard this argument mostly from young males. They're not placenta-making.
They are not placenta-making. I have not seen any attempt to scientifically explain the sperm thing.
Just kind of more thing.
I think it's just morphing of the word infertility. That being said, there are strange corners of the internet that I have yet to visit. So if anyone finds the scientific explanation, let's send it along, and then we can try to sort through it and see what there is. I did catch a paper a couple of weeks ago that came out actually evaluating semen quality and sperm count in vaccinated individuals, and spoiler alert, they seem fine. So I don't know that the clinical trial would be convincing, but I don't know where this information comes from, so you never know. All right. 3 times, not a thing. So we have not a thing on paper, and we have not a thing on paper, plus in a lab, plus in a clinic. So this is a really good one. Okay. Antifreeze. It contains antifreeze. Okay. I'm going to do a creepy thing and run right at my camera for the people watching, but I want to make sure I don't read this wrong. Where does that come from? So if you look at the ingredients in the Pfizer vaccine, it contains something called polyethylene glycol. Exactly. I was going to read the whole name of it, but I think it's just easiest to keep it at polyethylene glycol. So anyone who's done any lab work might recognize polyethylene glycol, or PEG, as we usually refer to it. It's a big, gross, icky phospholipid. It is very good at swelling up and disrupting, not breaking per se, but just disrupting a little bit cell membranes. Does anyone know what the chemical name for antifreeze is? Yes, it is. It's ethylene glycol. So polyethylene glycol. Polyethylene glycol does not equal ethylene glycol. And for anyone who thinks, it's the same thing. Poly just means many, so it's just a bunch of antifreeze. I'm struggling that if the number of carbons doesn't matter, offer to give them a cocktail made with methanol rather than ethanol. And they will quickly see that one carbon makes a big difference between a fun night and being dead. Number of carbons matters. In this case, it makes a beautiful vaccine delivery construct versus antifreeze, which is definitely not something that any physician would inject into anyone, because that would be bad. And you would get sued.
That's assuming the patient makes it alive, right?
Well, their family member. But yes, so this is one of those, again, that, if somebody looks at the label and you don't have the context to read the label, which again is totally fair. I can't read labels on a whole bunch of things that I have to do with and have never met before. The user agreements in mutual funds are like a different language to me. I don't understand any of that, but I wasn't trained in that. Therefore, I ask the accountant what it means, and the accountant tells me, and then I say, okay, and then I sign the thing. I just realized that that might be how a lot of people wind up in jail. Anyway. I heard it as I was talking. But the point being, like, if you don't make a habit of reading and discussing organic compounds, polyethylene glycol, ethylene glycol might ring a bell to somebody and be like, isn't that antifreeze? So you can get where it comes from. But I think that just the idea being like, this is not antifreeze, it's another compound with a different and similar name, because they are chemically kind of similar, but they do very different things. And feel free to use the ethanol methanol argument if it's, because yeah, I mean it's one night dead. It's a big, one carbon, big difference. So that's the thing. And so if anyone also could ask, why is polyethylene glycol in the vaccine? Because I find a question, let's discuss that. All right, mRNA. Anyone ever work with RNA in a lab? Yeah. Stable molecule, very easy to handle. No, it's a right pain in the ass to handle. Okay, so RNA degrades if you look at it funny. You could imagine injecting a sad little piece of mRNA into a big giant scary muscle and then hoping it finds its way to the regional draining lymph node is not going to be effective, because it would probably see the inside of the syringe and go, ah, and degrade. So we have to put it in something in order to keep that from happening. And so all of the developed technology around these new vaccines, most of the advancements, because people have been trying to do nucleic acid vaccines for 15 years, what makes this different and what they had been working on for so long at BioNTech and NIAID was, how do you deliver this? And so what people came up with was, if you put it into this nice lipid capsule, you can call it a liposome, you can call it a lipid shell. It's not exactly a liposome, but some people are referring to it as that. But the lipid shell here is essentially made of polyethylene glycol and a few other phospholipids. And they essentially mimic a cell membrane. They keep the mRNA protected, and then when it gets to big giant cell, remember I said it kind of sort of disrupts cell membranes a little bit, not enough to damage it, but enough to disrupt it. That's why you want to disrupt this membrane a little bit, so it lets this in. And then it gets inside the cell, and then it can go to the yoga studio, but not the nightclub. All right, so polyethylene glycol is not ethylene glycol, but it's in there for a really important reason. And here is that reason. Because wimpy pain in the butt molecule cannot possibly fend for itself when injected into a body. It needs to be hand carried, and the PEG is what's doing it. Yeah.
On top of that, isn't polyethylene glycol what they give you if you're going for a colonoscopy? Like, isn't that the diuretic thing? You need to clean out.
It is one of them, yes. And it's actually
Take it all right.
yes, and in fact, if you have polyethylene glycol is the active, and I think it actually might be the only, and I don't quote me on that because I don't have the label in front of me, but it is certainly the active ingredient in Miralax. So if you have ever, and actually I think this is going to be an important point, and I'm really glad you brought that up actually, because it's a wonderful answer. When this vaccine is approved for children 6 through 12, I think there's going to be a lot of nervous parents under, potentially again, not understandably so because I doubt the safety or efficacy, but understandably so because people worry about their kids, which makes sense. But if they say like, the antifreeze is, what is this chemical? You'd be like, it's Miralax. You probably already given it to your kid at some point because prune juice does not work as well as advertised. Anyway, just for my children who are now probably going to be mortified that I said that. Whatever. So yeah, no, it's the key ingredient in Miralax, and you haven't learned this yet. You'll learn it in, I believe, block 4 when you talk about GI physiology. But so long story short, diarrhea is a kind of umbrella term. There's various different things that lead to it. And one of those things is osmotic diarrhea, when you have like an imbalance between salts, sugars, and water inside and outside the epithelial cells. Osmosis is a thing, and it tries to rebalance that, and then you have this massive outflux of fluid into the colon, and yes, but no, that you are absolutely right. So it is something that people take routinely and give to their kids routinely, actually. Okay, so we got antifreeze. All right. Want to make sure. I feel like this room should have a clock right there, so person can like know how long they've been talking. But alas, that's why I keep looking at my phone.
Okay, this is broken. It's been at 12:30 for like 2 months.
Oh. That's outstanding. You're like, there's a clock right there. It does not work. Okay, so number 4, this was rush. Okay. Totally fair question. How many people know the ins and outs of the process of FDA approval? Like nobody.
You got
Right.
tested.
Sorry?
You got tested.
Oh, okay. Nothing of checked in on
Double blind randomized control.
So before the first week in July, when you arrived here and started medical school, who knew anything about the process of FDA approval? And you guys are interested in medicine. So you might, by non-random sampling, have some interest, but most people don't ever think about it, care about it, have any insight into the process, because it's boring, and why would you if it's not what you do for a living? Okay, so that being said, I think it's totally fair when somebody looks at a drug and says, well, that took 15 years to be available, and this took how many months? Just a handful? There's no way that's not rushed, but there is a way. And so here's what they did. They did the first, for starters, again, as I sort of alluded to, these are vaccine platforms that the scientists at NIAID, National Institute of Allergy and Infectious Disease, the thing that Fauci's in charge of, and scientists at BioNTech, they had been working on these types of vaccines for 10 years. And at BioNTech, they've been trying to use DNA vaccines for longer than that. They were trying to develop cancer vaccines, but so this is not a technology that somebody like Manhattan Project on the back of a envelope and said, I think let's shoot it into people. No, there was an incredible amount of background research on mRNA lipid delivered vaccines. There were animal models and trials in animals based on SARS and MERS. And so all they did was basically say, all right, we essentially have this platform, it's all made. We're just going to take the sequence that encodes the spike protein of MERS and pop in the SARS-CoV-2 one and keep everything else the same, because we know in the animal models, this was safe, it was effective, it protected them against viral challenge, blah, blah, blah. So it really, it seems new to the general public, but it really wasn't new. It's just that the general public had no reason to ever be aware of it. So there's that. It really was not a new platform. The second thing, what was done first, as noted, was the first thing you have to do is a phase 1 trial, meaning small number of people, and you make sure that what you're injecting into them is safe, is not toxic, is not going to cause them adverse reactions. You don't care if it does what it's advertised to do at this point. You just want to make sure it's not dangerous. All right. So they did that one by itself, was not dangerous. So then what they did was phase 2 and 3 ran concurrently, where you're looking small scale at efficacy and then big, wide, huge, thousands and thousands of participants. So those things were done at the same time instead of being spaced out. The other thing to consider is, so all the trials were done, it's just that they weren't done with the big giant gaps that usually occur. Because 2 things happened that didn't happen in this instance. All along the way, when you get all your data together and apply for FDA approval, that is a process that takes years, because you have to wait for the right people to be able to review the trial and deliberate and set the date for when they're going to have the panel meeting, and then everyone has to go to the panel meeting, and if everyone doesn't agree the first time, then you have to do a second panel. It's like a whole thing. And then you go back to the people and say, well, here's what we need to see in your next phase and blah. And then at that point, these people then go to their advertisers and their market actuary dudes and say, we would have to spend this many dollars to do this next thing in the trial. Do we think that medicine is going to sell well enough to justify doing that extra trial to do that, to get clocked? So you have this whole like marketing business thing that happens. Then they say, yes, we're going to do the trial. Then they plan the trial. Then they recruit patients for the trial. Then they have to actually run the trial. Then they have to go back to the FDA, get back at the end of the line, wait for the panel, wait for the thing. So all of that kind of stuff was just skipped. So most of the waiting and the years it takes for FDA approval is not spent studying the drug, it's spent doing that hurry up and wait routine, where you're waiting for the FDA to evaluate the study you did, and then you're waiting for the actuaries to do the market analysis, and then you're waiting for the board of directors to decide if you're going to move forward with the next phase and blah. So it seems rushed, but everything that was done in every clinical trial was still done. It's just all the waiting and all the analysis was just taken out, because there was no trouble recruiting subjects, because everybody in their grandma was like, please, I want to get into a clinical trial. There was no problem in terms of market research, because the federal government had committed in the United States, but in a lot of other countries as well. Federal government said, we will buy X number of doses, even if it doesn't work, we'll still buy them. And yeah, so all of that bit was just taken away. That's why it happens so quickly. So, which it's a fair question, because like, who actually thinks about that stuff in their daily life unless you do it for it? Most people don't. So seems rushed, but really wasn't. Okay. So do we need to bring up the microchips? Can we just agree that's not a, because honestly, I don't even know how to talk about that. Other than to say like
I don't think we're there yet with what we know about what atoms can and can't do. You can't inject, and then once it's in, it's out.
actually, no, I do have a comeback that I the microchip argument, and it is this. what information is that chip going to give somebody that your phone is not already doing? That is my answer to that.
And you get Wi-Fi to work, why would you miniaturize it and give it to everybody?
Exactly. Yeah, like, maybe my chip will like kick in when my 4G goes out or something, I don't know. But,
So we can get better Wi-Fi now.
exactly.
Great.
Lost in thought. Okay, but. So the last thing to bring up, I think. So the last one to bring up, I think is an excellent point, like when people say that I'm just not convinced. I think I would respond to that with 2 questions. And the first would be, what would convince you? Because often when you actually make someone answer that question, they end up talking through their own thoughts, and they usually end up convincing themselves. So there's a lot of neat studies where people do this with undecided voters, where people say like, well, I can't decide who to vote for. And then you just say, what would help you make that decision? What do you need to make that decision? And then by the time they talk through it, it's very clear who is best aligned with their values. And it's, and I'm not, saying that with any kind of slant to it. It's just an idea of someone making what is to them a very complicated decision. Because oftentimes all the stuff they need is in there. It's just, they haven't processed it yet. So what would convince you is a good one. The next one is, and this can be tricky because if you do it wrong, it comes off as very condescending. If you can say, you're not convinced, but thousands of physicians are, and thousands of nurses are, and thousands of scientists are, what is it that you think they are missing that you have? And oftentimes, because that can sound so condescending, I mean, I never say something like that without also following it with like, I don't want my plumber to ask my opinion because I don't know anything about that. And if I gave it to him, it would probably be a disaster that would involve flooding of some part of my house. And so I think when you ask that question, it always has to be in the framework of, and this isn't, this is, I genuinely mean this. Everybody has a thing that they are incredibly well trained at and very, very good at. And it's just that sometimes if that thing is not how to evaluate a clinical trial or what the ingredient label on a vaccine is referring to, I get that there's an emotional piece to this when you're saying like, what I'm going to put that into my body and it could change me. The other thing with the convinced argument is we know what COVID will do to you. Like we know what it will do. We know you have an X probability of dying. We know you have a very non-negligible chance of winding up with permanent physical changes, or at the very least, long-term physical changes. And whatever minuscule event might happen in reaction to a vaccine, which millions of people have now received without massive consequences, what is in there, whatever that risk is, is in no way comparable to long haul COVID. And I think the other valuable thing to do when someone is not convinced is to have, there are a lot of YouTube channels and podcasts and blogs for people with long COVID. And people are just describing what is their day like now. You know, people who used to run 10 miles have trouble walking up the stairs, and how did this change their life? Because I think that can actually be incredibly powerful. And long COVID is something that we do not talk enough about. And I think that that would be very, very powerful, because it's not just, I will get it and die, or I'll get it and recover. There's this huge area in between. And then, yeah, I don't know, my other thought too is, and this is what I had the most anxiety about the entire pandemic. It's not just if I get it and die. I'm not per se afraid of dying. I'm afraid of my children having to live without me. And I'm afraid of that trauma. I would be especially terrified of it if they got it at school, gave it to me, and I died. What would that do to them mentally? So when someone is not convinced, long COVID is an incredibly persuasive point to make, but also you may not be afraid of dying, but think about everyone in your life and how they would react to you not being there. And I think it's a perspective that is uncomfortable to, it's an uncomfortable thought exercise for a lot of people, because we don't, as a species, like to face our own mortality. But if people are being asked to make a decision about something that could prevent them from having to face mortality, so it's a valuable thought exercise to do, at least in my opinion. Did you have a question?
Yeah, I was just gonna mention, have you heard the argument that people are now saying like, there's ivermectin and not say.
Oh, Christ. Oh, yes, and monoclonal antibody theory,
Yeah,
or monoclonal antibody infusions,
yeah.
which makes me want to tear my hair out, because I can be like, you know what is way cheaper and easier than monoclonal antibody infusions? A vaccine, which is the exact same thing, except you don't have to get sick first and take up a hospital bed while you're being treated. So yeah, so there've been, like hydroxychloroquine before it, there have been a couple of studies where people looked at the antiparasitic drug ivermectin, which hopefully we remember is distributed prophylactically to prevent river blindness to very vulnerable populations. So if we could like not divert ivermectin for nonsense would be really great. So the, yeah, there have been a couple of trials that seem to hint at efficacy. They are not well designed. Their N values are very small. These are published studies, but they're not particularly persuasive, I would say. The other thing too is like, I'll just take ivermectin. It's, as we know, parasitic drugs are a real joy to take, right? But the other piece too is you're diverting a very critical medication for people who actually need it. And then the other piece is, since we don't know that works, and we do know the vaccine works, why would that be a thing you would rely on? Because I think a good thing to do would be, I like the point about diverting a critical medication, because I think it's something not very many people know what ivermectin is used for. I mean, it's used in veterinary medicine a lot too, but the other thing I would do is like, you should pull up the side effect list and say like, vaccine gives you a fever and you feel kind of icky for a day, which is not negligible if you have to work or something, but ivermectin, here is the side effect. It's not an easy, it's kind of like, why are you happily willing to take this while you are critically ill as opposed to this. It doesn't make any sense. Anyway, at least not to me, but who am I? I think you were next, then you, then
I have a couple of friends who I was really, really close with in high school and still keep in touch with. And two of them are rural nurses here in Maine.
Mhm.
One close to my hometown and the other a bit more farther north. Both have just had their first child and both are not vaccinated, nor do they plan to get the vaccine. So this falls in both camps. This is the infertility camp. And then in part, these people, these individuals support the non-convinced people because these are two nurses who also were educated at, in my opinion, a very good school. Like they are not aware, but I think maybe have not found the right resources. And so that's like a separate problem. But for those folks who do come to you and say that I'm not convinced, and when you do, if you do opt for option 2, which, you know, if you can make it not condescending is great, but what if they then come back at you with like, oh, I have a nursing friend or a friend who's a PA or a doctor or whatever who's decided not to get the vaccine? Like what, because it is so confusing to me personally, why somebody would make that choice who's in healthcare and
Totally
has
understood.
a lot.
totally understood. Because there's, with Maine's new vaccine mandate for healthcare workers, this has been actually discussed a fair bit. Especially there's one of the EMT companies, or one of the ambulance companies made the point that they might have trouble recruiting EMTs because there's a fair number who don't want to be vaccinated. I think, to me, a way to make this, and again, it's a really tricky one because they have to be open to it, is as you all appreciate as medical students, you know how much immunology and micro you just learned. So the immunology you learned in block 1 is pretty much it. Like there's a few more things sprinkled throughout year 1, there's almost nothing in year 2. So this is all the immunology you are going to get, pretty much. 15 years from now, if you have been practicing as, say, a dermatologist, how fresh is that going to be for you? I know this is a really awkward time to ask you that because you just had your block exam. Like, that is tattooed on my brain and it's never going away. But the thing is, there absolutely are CNAs, EMTs, some nurses, some physicians who are like, I'm not getting vaccinated. When you look by specialty, one of the things you can notice is, and you see it with biomedical scientists too, there are a few who get, and they go on YouTube and make these videos and people are like, see, that's a doctor and they said this, and you're like, well, that person's like a biochemist, which is fine, but this is not a biochemistry problem. This, this is an ID problem. So one of the things that you can point out is if you look by specialty, how much training the person has had in microimmunology and path, the more training they've had in those specific areas, the more likely they are to be vaccinated. So if you look at an average nursing curriculum, there is no immunology in it. And if you look, most nursing programs have to take micro, or I should say most 4-year nursing programs, they have to take micro, but it's one course. And it's, I've taught it a couple of times at different universities. It's a different micro course than the pre-meds and the biology majors take. It's not as in-depth. And so, which is not to say it's not hard and everything like that, it is, but it's a different thing. So sometimes we tend to, not so much you as medical students, but the public at large, people tend to think of healthcare workers as like this monolith. And there's very different levels of training and exposure all the way up and down that monolith. And so, So we can't, so that's, I think, a tack that I would take, perhaps not with the nurses themselves, but when somebody says, I have a friend who's a nurse, then it's just sort of like, an ID physician is going to be way more qualified to speak about this than a CNA because they've been exposed to it so much more. On the contrary, just like an ID physician is not who you want to ask about physical therapy regimes. Like that's, yeah, like I might remember something from first year about that, but I haven't done it in 10 years. Like, why would I know about that? So it's like, they might know more than the average rando, but if a physical therapist is saying something different, like that's whose opinion you want. So I guess that's kind of how I would look at it and how I have been kind of dealing with that same question actually. Just that healthcare workers are not a monolith. Yeah.
So my question was kind of piggybacking on an earlier one, and I think it's more towards like the future is like a healthcare community and messaging rather than potentially this one, because I think obviously right now we're in medical school and it's more on like case by case basis. So I think unfortunately.
And this is such a weird scenario all around.
Obviously this particular has been so politicized, and with the politicization of it comes a lot of like cognitive dissonance and when keeps and stuff.
Absolutely.
Vaccinations and stuff like that. But so for example, you're talking about monoclonal antibodies earlier, which again do have there's some evidence that shows like that they can be helpful.
Oh, sure.
But as you said before, also it's much better to have your own antibodies fed, which would be much more helpful if you just have
Infinite
vaccine.
supply.
But I do also think that like there's a lot of like genetic nature that if you're on fence something where it's like, oh well, if I got sick, there's a fail safe for me. Like look at this treatment coming out. So, like now I can take my chance of not getting the vaccine. So because if I get sick, there's this treatment there, and it's not just. I mean, you hear people getting into the hospital like, "Can I get the vaccine now?" And it's
Yeah, you're like, no.
and so how is a healthcare like professional communities in which can we be better at more homogenous and like messaging to get it out like more of a clear cut thing to people to be like, this is what you want to be doing instead of, I feel like sometimes that's kind of the hardest part is that people have all the thoughts in their head of like, this is why this treatment makes sense, but like having a consistent message across the board, across like all forms of media kind of gets lost in the translation.
Well,
Which is why
I think we have that to a little bit of an extent, and it's, when I was a kid, the CDC was called the Centers for Disease Control. It's now called the Centers for Disease Control and Prevention. So there is sort of this theme about prevention is the best way of maintaining health. And in the terms of COVID prevention, hands down, the best prevention you can have is getting vaccinated. The other thing, and I think that when you say that, sometimes you might get somebody like kind of rolling their eyes at you like, okay, Dad, fine, I'll eat my broccoli. But the other thing, and maybe this will be persuasive, like, have you looked at some of these hospital bills? Like, this is another thing people aren't talking about, like this treatment, the hospital care for all of these, this is costing a fortune. And so if somebody does survive COVID, comes out of the ICU, they're gonna have $100,000 bill waiting for them.
Or more.
Or more.
Or 9,000, depending on how long you were, and if you were in the ICU, forget it.
Yeah.
And if you're in there with a preventable, I mean, I don't know if it's come to this yet with insurance companies, but I believe there will be a day when they'll be like, oh, you didn't get vaccinated, and then you ended up here, and then you got into the, I mean.
People
do you
are
know what I
already
mean?
talking about that.
Yeah, I don't know if it's even really been a full conversation, but
I think it would be, it's, to me, it's like questionable legality on a
Right.
policy that a person currently holds. But yeah, futuristically, what's to stop an insurance company from saying, we will not cover care for something that you could have prevented it didn't?
And I think even also like best case scenario is that a lot of insurance companies with the way that our insurance market currently is are probably going to define having COVID as a pre-existing condition. And so your insurance premiums are going to go up just from having COVID because it's potentially going to be things that are tied to long COVID that, I mean, unfortunately, a lot of insurance companies can get away with raising premiums at this point. So
which is why pre-existing conditions were specifically named in the Affordable Care Act. The first version of it anyway, but
We stripped it down, so.
oh, oh God, that's another story, but yeah, no, so so prevention is to me like a great communication strategy, but it doesn't work on everyone because we all think that it's going to happen to someone else. And so I guess another really persuasive one to me is like, look at those hospital bills. These people, if they survive, they are coming out like absolutely hobbled with debt. And that's just and if they have long COVID, they might not have disability, they might have already tried working and they've got all, that could be persuasive on a practical level, I think.
Sure.
Yeah.
What about, I'm sorry to go back to the questions, but like, a family member came or asked me about Robert Malone, who's a viral. I'm sure that name you know who that is. So she's like, my mom's like, your uncle is a physician, worked with him at UC Davis, and he's saying not to get the vaccine. I did a quick search and found that he's in trouble for spreading misinformation, but to her, it's just confirming.
Right, because it's like, that's a personalized thing. Dr. Fauci is like,
Right.
you know, he may as well be a centaur at this point, you know. But Robert Malone is a friend of your uncle's, you know, so it's hard to break through that. I will say that every profession has its problem children. It's so hard because in this instance, there is a personal connection. But what have you asked her, what does your uncle say about it?
So that
He could have been a perfectly fine physician, but he's wrong on this one account, you know?
So he's really religious and his church came out and said to get the vaccine, so he decided to put that aside and get the vaccine. So it's kind of, I don't know, it's interesting. It's his reasoning for everything, like you're a physician, you understand the science, yeah, what's convincing you to get the vaccine is not science, but.
But that is actually really important to some people, and actually we
They got it. We're good.
You got it.
They got it. Here's why.
it's actually an important aspect, and I didn't put it up here because we went through our, you know, in our kind of classic vaccine misinformation conversation, but you know, I don't know about you all, but I've heard the fetal tissue
Yeah.
circulating about this one too, and you're like, no, there were no cells being used, there's no, you know. You know, so it like old vaccine disinformation is like started to breed into this one, and you would look and say, all right, we remember where that came from, right? The idea you have to use cell lines from, you know, long since departed abortion remains that are used to grow actual viruses that are used to produce vaccines. So there's like that little kernel of something, but again, this is a donated fetus from a consenting family who was lost for medical reasons, and again, a cell line that's been replicating for 50 plus years. And even that, the COVID vaccine, which has no, the mRNA vaccines, there are no live viruses or dead viruses in it. There is no COVID virus in it. It is a synthetic construct entirely. Nothing to do with cell lines. Even that is getting kind of polluted with kind of these old things, because I guess the word of today is monolith, but I think sometimes in the general population, people think of vaccines as a monolith. And, a good I'm trying to think like what would be a good, comparison to a drug class you could make that would be a good one for people to grab onto, like maybe like NSAIDs or something. Or pain relievers, you could say, like, there's Tylenol and there's Motrin and there's Aleve, and they're all different compounds, but they're the same kind of class of things and they work slightly differently. So you could say vaccines are kind of like that, they're different kinds and, you know, different production goes into different kinds. So anyway, yeah.
So what would you say to somebody who's more vaccine hesitant rather than like an anti-vaxxer, somebody who like is at low risk for like going out and like getting COVID, but they just wanted to take the wait and see approach? What would you say to them?
Well, I think a lot of the same comments are with the, I'm not convinced. So I appreciate there are a lot of people doing the wait and see. And I think having a conversation with a person now in August 2021 is rather different than August 2020 even. Because the Delta variant has really changed the game in terms of a risk calculation. But I don't know that everybody in the population realizes that yet. I think if you grab anybody on the street and say, you know what the Delta variant is, they would say, yeah, I heard it on the news. But why is Delta so different and why should it change your thinking is something that I think is a little bit missing from the calculus, because, you know, we'd say, okay, it's more transmissible, but it's landing younger people in the hospital, it's making kids sick, it's doing all kinds of things that, you know, OG COVID was not doing. And that you need to redo your calculus at that point, because waiting and seeing for something that you feel is not going, you know, has a low risk of giving you bad consequences is one thing, but waiting and seeing for something that there is a real risk of bad consequences for you is different. And so you need to, anyone who's saying wait and see, I would kind of say, have you really thought through waiting and seeing in the face of this one versus that one? Because, I mean, as you can imagine, it's hard for me to take off my own lenses with this kind of thing, but because I'm thinking like, I got vaccinated the second I could, but I mean, if I had felt I wasn't at risk, you know, last year, I would feel differently now, because the risk is very different now. And yeah, and then I think the other, so I would say, have we rethought this in the context of Delta? And then I would also go back to, if you have rethought it in the context of Delta and you've still decided that, you know, I'm gonna wait and see, you know, I'm not going out to bars, I'm, you know, wearing a mask at the grocery store, the whole thing, you know, person behaving responsibly. I would just say, have you gone through the thought exercise? If I got long COVID, if I could no longer work, what would my life look like? If I died, do I have, you know, does the person have children? Do they have a spouse? Are their parents still living? What would that do to their, you know, do they have nieces and nephews? What would that kind of do to their family structure? Because when you make these things real and tangible, because right now the vaccine's the thing that's real and tangible. And COVID is sort of over there somewhere. And I, you know, I might theoretically know I could get it, but, you know, I'm wearing my mask and I'm not going to get that. If you make that as real as the vaccine, then I think that it becomes a no-brainer at that point. I'm going to, you know, I'm going to get a fever and feel like junk for a day or two, or I may be fine, or these truly awful things might happen to me or my family in my absence. And I just, when you make the risk more real and personalize it like that, like think about what would your mom say if she had to stand at your funeral? I just think that makes it more real. And if they still say, well, nope, that's how I feel, then at that point, like, I don't know what else to tell you, but it's, yeah, so, and I don't know, I apologize for being slightly passionate on this topic, but it's, I mean, it's different. I remember Dr. Brandt when we were doing the grand rounds with the one patient visit, and she was, having that kind of physical shaking reaction. I've been having that for the past month, thinking about my 7-year-old going back to school. It's the very same impulse, like you can do whatever you want. You are putting my kid at risk, and I am not okay with that. So it's been a thing. Yeah.
What about individuals who have already had COVID and choose to get the vaccine? They have natural immunity?
Yeah, so that's a great question, because there's also kind of a narrative that natural immunity to a disease is always better than vaccine-derived immunity. For COVID in particular, and actually all coronaviruses, we know that is absolutely the opposite of reality. It can be true for some pathogens, right? Like natural immunity to measles, for example, is fantastic. You've got that sucker for life, but natural immunity to coronaviruses, they're very immunomodulatory. As we can see, like people die of cytokine storm. And so we know they're very immunomodulatory. So they actually give a really kind of maladaptive, craptacular adaptive immune response. So if you get COVID, you will have antibodies, sure, but they wane very quickly within, just a span of months. And they do not seem to, and this is again a genus-wide point about coronaviruses, their adaptive immune response they stimulate is very junky, and it's junky intentionally, right? So that they can come reinfect you. So one thing is, yes, you will have made an immune response if you got COVID. However, we know that for this family of viruses and plenty of case reports for SARS-CoV-2 itself, that immune response is protective briefly, but we have every reason to believe it wouldn't be protective long term, first of all. And second of all, the other piece is, a second piece is that some patients who had long COVID actually found that the vaccine diminished their symptoms a bit, which was helpful. Not all patients with long COVID, but some. And a third piece too would be just to give reassurance. If you got COVID and then you get the vaccine is not going to hurt you. It's not going to cause like a hyper exaggerated immune response. You could liken it to say, well, if you get a flu shot, but you got the flu before, it's, you're essentially doing the same thing. You're boosting against a disease you've already had. It doesn't give you, it doesn't make you resume having the disease, or it doesn't give you any kind of autoreactive responses. So getting the vaccine is not going to hurt. And in the face of their natural immunity that they developed when they were sick, again, it's not likely to be protective in the long run. The risk calculation there would be like, I would still get the vaccine. Hopefully that's helpful. Because I could see a person saying like, yeah, I already had it, so I'm good. But, which is a totally valid conclusion, but here's the context. Yeah.
Going off of that, when we talk about the Delta variant, is it just like, is it the change in the epitope that makes the variant, or does the variant itself affect work on the body differently than the original SARS-CoV-2?
Yeah, so that's a great question. So It's a little bit of both. So the spike protein, the vaccine antigen, is a teeny bit structurally different, but it seems our vaccine-derived immunity still neutralizes it for now. When we think about the function of the spike protein during coronavirus infection, so remember our virology lecture, our general virology lecture, when we talked about locks and keys, right? So receptors and ligands. So the spike protein is the ligand. So that's how the SARS-CoV-2 virus grabs onto the cell. So that being said, that being a little bit structurally different, it's extremely functionally different though. And the functional difference is that you have interactions that are you have interactions with cells that are higher up in the respiratory tract. So you have this enhanced transmissibility. And one of the other pieces that we know is that the replication dynamics seem a little bit different because people who are infected shed greater numbers of virus. And the piece that people are thinking about, but I think has not quite been demonstrated, is it's plausible that in addition to shedding higher numbers of virus, it may also take fewer to establish an infection. So the shed rate has gone up and potentially it's starting to look like the infectious dose has gone down. And so between those two things, you've actually got quite a, the practical reality is that it's easier to catch, it's easier to transmit. And then as to why it's affecting younger people and children differently, we're all still trying to figure that one out. But it definitely, though it's not clear why, it's definitely clear that it is. And I don't know, I mean, I'm looking at all this hesitation against the backdrop of the state of Alabama literally has 2 ICU beds in the entire state left. That was last night, and they could be full now. Yeah, Texas doesn't have any. Texas is, I know at least in Houston and DFW, the PICU beds are all gone.
Same as in Florida.
Yep, and yeah, so in Tampa and Miami, the PICUs are completely at capacity. A scary thing too is that if we don't have mitigation for kids under 12 in terms of vaccine, yes, but masks and distancing as well, which, you know, schools are currently, school boards across the country are fighting about right now. If we don't have that, the thought would be looking at transmission dynamics and case totals and what is the pediatric population in the country and how many go to public school and all that kind of thing. When you do the math out, it would look like we would need about 6,500 ICU beds if we don't do, or PICU beds, I should say, if we don't do mitigation, and we've got 4,500 in the country. And the other thing, of course, to point out is that they're not evenly distributed, right? Like we have more in Boston.
Nurses.
Or
Are they fully staffed beds?
exactly. That's,
Probably not.
no, exactly. And it's not even, one of the things too that I think is if you've not kind of seen the environment, it's hard to understand. Like a PICU bed, a pediatric ICU bed is not just a smaller version of an adult ICU bed. Like the equipment's different, the dosing standards are different, the training is very different for the nurses and the doctors. And so, and the pulmonologists and everything else. So it's sort of like that could this could be catastrophic.
Yeah, you can't have the same kind of help that we did originally.
Right.
And yeah, because adults, you could still get the neurosurgeon to be like, okay, brush up on this, come help.
Right, exactly.
It's a totally, you don't have any of that.
No, you are absolutely right.
Third booster shot, just the staffing, right? We're going to do a third booster shot for everyone. Remember how we got so many people vaccinated? Every convention center was filled with National Guard and like everyone. Are we going to remobilize that to get everyone a third shot?
I mean, I know my mom would get back up there if she was doing the same, but she loved it with the National Guard. But now after everything what's happening in Afghanistan right now, the National Guard, anybody who served is gonna be so, I mean, there are so many more variables now that I think are gonna make all of that so complicated.
I think too, like I was a healthcare worker during COVID, and I think the way that we were treated throughout the whole thing is going to deter a lot of us from wanting to bring them back to our house.
Yeah, I so agree.
No, and that's, you bring up an amazing critical point, you know, being a healthcare worker during COVID was one thing,
So.
but it did, you know, it was traumatic and it sucked and on every level. But there was this element of, you know, everyone in New York City clapping at 7 o'clock at night and parades and blah. And now, I mean, just the voices of those physicians that are being interviewed in Alabama, like just the idea of people coming in and just, I don't know, just there's this idea of like, you want me to help you now?
Yeah.
You know?
Yeah.
And after you've been accusing my profession of lying for months and exaggerating, and now you want me to break my back helping you? It's a real, which is one of those things where it's sort of like, you know, it's not professional to feel that way, but it's an incredibly valid feeling. And I don't know,